Yesterday, a child came out to wonder.
Welcome to Gracefully Graying. I'm your host, attorney Henry Gornbein. Every week on Gracefully Graying, we explore issues that we all face as we are hopefully gracefully graying or have aging parents. Today on Gracefully Graying, we are going to be exploring issues with regard to benign prostate hyperplasia with my guest, urologist, Dr. Brian Seifman. Dr. Seifman, welcome to Gracefully Graying.
Thank you for having me.
Brian, why don't you tell us a little bit about your background and training?
Sure. So I was born and raised in Michigan. I actually grew up in Farmington Hills, so just a few miles away from here. Went to North Farmington High School, and then I've pretty much stayed in the state for my life except for vacations and that kind of thing. I went to University of Michigan for undergraduate, Wayne State University for medical school, and then I trained at the University of Michigan.
What made you decide to go into urology?
So when I was a first-year medical student and I was living with somebody who was a year older than I was, he said to me, "Brian, you should be a urologist."
Had you thought of other fields before, or?
You know, the only other fields I really considered was actually going to obstetrics and gynecology. I briefly thought about ears and nose and throat, but when he said to go into urology, I knew nothing about it. And so I decided, well, I'll go and look into it. I met with one of the urologists at Wayne State, spent some time with him, spent some time with the residents. And the residents there really were enthusiastic about urology. They enjoyed teaching. It was contagious to me, got me interested, and that's why I decided to go into it.
Once you finish your 4 years of medical school, what additional training did you have for your specialty?
So after medical school, my residency was at the University of Michigan. My total residency was 6 years. I did 1 year of general surgery training, and then I did 5 years of urology, one of which was doing a year of research. Most programs now are usually 5 years rather than 6 because they eliminate the year of research. Once I finished that, I then stayed at the University of Michigan and did a fellowship or additional training for another year. That was done in what's called endourology, which is basically doing minimally invasive surgery and also stone disease.
What is benign prostate hyperplasia?
Essentially, it's your prostate's getting bigger. And all men, as they get older, their prostates will get bigger.
Is there any reason for that?
We're men and we're getting older.
Yeah.
And so, everybody's prostate starts out at a different size. Everybody's prostate will grow at a different rate. So some people won't have much problems. Some people will start having problems in their 40s or 50s. Some people may not have issues till they're in their 70s.
But almost no one escapes it. Is that accurate?
Probably about overall 70% of men will have some kind of problem with their prostate during their lifetime.
What are these symptoms?
So for benign prostatic hyperplasia, or BPH as most people would refer it as, they're mostly urinary symptoms, meaning slower stream, getting up more at night to go to the bathroom, maybe having to go more frequently or having a little bit of urgency. Some men will have to bear down or strain or push their urine to get it out because the prostate's growing so much it's actually blocking the opening of their bladder, so they can't necessarily go. In severe cases, they may not be able to urinate at all.
And what are the tests you use for diagnostic purposes?
Sure. So, in general, after taking a history from the patient and hearing about their symptoms, and then you need to do a physical exam. So, examining their stomach, making sure you don't feel an enlarged bladder. You want to examine their prostate, examine their penis, make sure you don't see a stricture or narrowing at the opening. And then when you do the prostate exam, which is a rectal exam, you get an idea of how big the prostate is. Now some prostates may be very large on exam, but they're not necessarily blocking the opening on the inside. Some prostates may be small on the outside and bigger on the inside. So sometimes you have to just go by their symptoms and may need more studies to figure out what the next step is to do.
And what is the next step once you are suspicious that clearly there's a problem?
So one thing that we always want to look at is a urinalysis. Sometimes the urine can look like there's an infection, And if there's an infection, that may be the reason why the person may have more sudden onset of symptoms. Most people with BPH, because it's a gradual growth of the prostate, it takes usually sometimes many years for them to notice how bad their symptoms actually are. So certainly checking their urine is one of the first things that we need to do. Oftentimes we'll actually do a ultrasound of their bladder to get what's called a post-void residual. So the patient will actually urinate, try to empty their bladder normally, and then you do a scan or an ultrasound of their bladder to see how much is still left behind. If there's a lot left behind, that gives you an idea that there could be more of an issue with their prostate. From there, there's a lot of other tests we could potentially do. So we may try some treatment first before going on to sometimes more invasive testing. There's some non-invasive testing we can do as well. So there's something like a uroflow test. You come in with a full bladder, you just pee into a little measuring device, and it measures how much urine comes out and at what rate it comes out. It gives you some general idea of how well it's working. There's a more advanced test after that that's still non-invasive called the Urological test, where it's the same type of flow test, but there's actually a blood pressure cuff similar to it, obviously smaller than one that goes on the arm, that goes around the penis itself. And then when you urinate, that will actually inflate and it will actually stop your urine stream. And what it's doing is it's measuring the pressure with which you're urinating with.
Is that new?
Relatively. So it's probably been out for about a year, that type of non-invasive testing. That will show you that Urological test. If you have a high pressure from your bladder, meaning that your bladder is squeezing really hard and your flow rate is low, so you're not urinating very quickly, that will give you an indication there's some obstruction going on. So after that, then you want to see, well, where exactly is this obstruction? What does the prostate look like? And what does your bladder look like? So we could do a procedure that's called a cystoscopy, which is typically done in the office.
What is that exactly?
So what we do is we actually take a small camera, go through the penis, and actually look inside. We do put in some numbing jelly. I will not tell you that it's completely pain-free. It is more uncomfortable. It can cause some stinging, maybe make you feel like you have to urinate. But it doesn't take very long to do, but it gives you a lot of good information. So you can make sure there's not any scar tissue in the urethra or the tube that you pee through. When you look at the prostate itself, you can see, is it obstructing on the sides? Are the sides of the prostate enlarged? They're enlarged what's called the median lobe, which is on the floor of the prostate. What the median lobe does is, if it's enlarged, in some people when you urinate, it'll actually flip up and block the opening like a ball valve. And so it gives you some idea of what treatment you would need, because that may be different with that type of obstruction. The other thing that we're looking at too when we look at the bladder is there a lot of thickened muscle fibers? So does the bladder look nice and smooth, or there are a lot of ridges and bumps to it? If there's a lot of ridges and bumps, it's usually because the bladder muscle is getting thickened because it's working so hard to get the urine out. You can get what are called diverticuli, or outpouchings of the bladder. A lot of people have heard about that for their colon, because people can have diverticulitis and get infections there. You can get infections in the bladder as well, because you're not emptying well, but it's also a sign that your bladder is working so hard to get the urine out that it actually acts like a little pop-off valve. And so it just starts bulging out some, so that way it helps to relieve some of the pressure in the bladder.
Can that cause permanent problems with the bladder?
It can cause permanent problems in the bladder and potentially kidney problems. So if you're not emptying very well...
So everything's interrelated.
It's all plumbing. It's all hydraulics. So as the bladder gets more and more distended and has to higher and higher pressures, one potential problem is that the urine starts backing up towards your kidneys. You can get dilation of the kidneys, and if it's not treated over a prolonged time period, it can actually cause kidney damage and kidney failure. The other issue in the bladder is that if your bladder keeps retaining more and more, initially your bladder can compensate, meaning it can increase the pressure and it can still get the urine out. But in some people it increases so much, it's not going to contract anymore. It's almost like a balloon that gets too blown up you blow it up and it comes down. You blow it up and it comes down, but eventually it gets so stretched out, it can't come down anymore. And then maybe, you can't urinate anymore on your own.
Is that fairly unusual where you have, I guess, total lack of the ability to urinate?
It's not very common. Usually when that does happen and you start talking to the patient, they realize that they've had a lot of symptoms. Some of it's denial. Some of it is, oh, I'm just leaking a little bit of urine, and they just sort of ignore it and think, well, I'm getting older, I'm just not going to pay attention to it. But really what's happening is that if your bladder's getting fuller and fuller, it can only hold so much. And so sometimes people get this quick urge to go and they'll start leaking urine, because if you think of the bladder like a bucket, it's basically just overflowing the top. So a little bit of more urine's coming out, but the bucket's still full. That's a problem.
Unscientific question, and that is, everyone talks about, how often do you get up during the night to go to the bathroom, and what's a sign that they're starting to have problems? If you're up like 2 or 3 times, 4 times, or what do you see?
Sure, so I usually tell people getting up 1 time at night, I don't have a big problem with that. But if you're getting up, if you're 50 and you're getting up twice, and then you're later 50s, you're getting up 3 times, and you're now a couple years later getting up 4 times, that's a sign that something is going on. Part of the reason why it's difficult to detect in the individual is because when things occur slowly, like most things, you don't pay attention to it. And you think, oh, I've been getting up 6 times at night for many years, and that seems normal to me now. When really, it's not normal, right?
Yeah.
When really, it shouldn't be normal. Or if you're having to bear down or really strain or trying to push the urine out, you shouldn't have to do that.
What are some of the treatments for an enlarged prostate, starting with, I guess the most benign, which I guess would be medications?
So medications is probably almost always the first place to start. Because like you said, they are predominantly benign. Most of them do not have a whole lot of side effects. Most of the side effects that we get from these medications, they're called alpha blockers. So they block the alpha receptor in the prostate. What that does is it relaxes the smooth muscle in the prostate, just makes it easier for the bladder to contract and get the urine out. There's probably 4 or 5 medications that are out there that do that. They're all functionally about the same. Some of them may have a little bit more side effects in terms of lightheadedness or dizziness. Some of them can have some other side effects, like what's called retrograde ejaculation. What that is when you have an orgasm, no fluid comes out in the front, it basically goes into your bladder. Medically, it's not a problem. It's just some people get a little bit concerned the first time, certainly, that happens. So that's usually the first medication that we would typically start with. And most of them are very inexpensive because they are generics. There are other medications that will actually shrink the size of the prostate. Those medications have a little bit more side effects in terms of they may have some erection problems or some
How
libido
effective are they?
problems. Those medications that shrink the prostate, first they usually take about 3 to 6 months to see how much effect that they're going to have. Their amount of improvement I would consider to be fairly modest, certainly compared to the first group of medications that relax that smooth muscle in the prostate. So those medications I would use first. If somebody wanted to try the other ones, they're doing okay. They don't have a severe type problem, and they want to try something else in terms of medication wise, I think it's reasonable to try it, just so long as their expectations are, they're not going to be chipping the porcelain with that kind of medication.
And what about, I've been through all this, and we can talk a little bit more, could be Exhibit A, I guess, and at one point I remember trying soft palmetto, didn't do anything, gave it to a friend who's had prostate issues, and he swears by it. And I guess there are other over-the-counter homeopathic remedies as well. What is your take on those?
Sure. So the first thing I would say is those medications, they're not going to hurt you. Whether the most common are saw palmetto and beta-cytosterol. There's others that are out there as well. Some people like to use pumpkin seeds and other things along those lines. But saw palmetto and beta-cytosterol, those are the most common that are used. Most studies have shown in double-blind, placebo-controlled studies, they don't have that much an effect. Saw palmetto is certainly not much better than a placebo. Now, there is a big placebo effect.
Psychological, yeah.
So some people may be feeling it from that. Beta-cytosterol is actually, there is some data show it has some effect and some improvement in symptoms in those types of studies that were done, but it's still not as good as the prescription medication.
Now, is prostatitis ever related to prostate issues as far as an inflamed prostate?
Usually,
can that be a side effect or has no relevance?
Not usually directly. If you're not emptying your bladder very well, you could be at also risk for getting some bladder infections. If you get a bladder infection, it can also spread to the prostate. Sometimes you do get high pressure urination, which can actually, in theory, push urine into the prostatic ducts and possibly cause more likely to have prostatitis that way. Usually I tend to keep them separate though.
Pills, placebos, they've all failed. What's the next step, Ryan?
So that's where a lot of that testing comes in. Because depending on how big your prostate is, we may need to do an ultrasound of your prostate as well to get a more exact measurement. There's some what we call minimally invasive procedures. There's something called a Urolift, which is relatively new here in the United States. They've been using it in Europe for a longer time. A Urolift is basically putting in an implant that basically kind of tacks your prostate open, so it opens up the channel by using these clips that basically hold it open.
It's just like, you know, what they're doing now with arteries and coronary?
It's a little bit different.
Okay.
Because those are more circumferential, or they go all the way around and they expand. There was something a long time ago, there's a type of prostate stent that's really not used anymore because those had a lot of issues with them. But that's one type of minimally invasive procedure. That kind of procedure takes roughly between 5 and 10 minutes to do, done as an outpatient, sometimes done in the office. There's other types of procedures where you can do them in the office, where you can look in the bladder and you can put needles into the prostate that can add steam to it, something called a resume. And over time, time being about up to 12 weeks, will actually shrink down the prostate because you're heating it, and so that causes the cells to die and then shrink down. There's been lots of other similar type procedures. There's microwave procedures.
How does that work?
So the microwave procedures, it's a catheter that has a microwave generator on the end of it, and it's using heat. And so just like the steam, it's just a different heat source. So you put this catheter into the bladder, so it goes through the penis into the bladder, and then it stays there during the duration of the procedure, and what it does, it actually heats up the prostate, and then the prostate, again, over the next 8 to 12 weeks, will actually shrink down. So those types of procedures can be done in the office. There are some anatomies that may make it more difficult or not able to do that kind of procedure. If you can't do that type of procedure, then usually we'll do a procedure in the operating room, and it's some kind of resection of the prostate or partial prostate removal. We could do where you go through the penis, so you can actually scrape out the prostate. There's different types of cutting currents to do that, maybe a little bit more specific than, or more detailed than what you maybe need to know here, but you know, where you can actually literally scrape out and just open up the whole passage that way. We can use lasers and do it with those as well. The difference with a lot of the lasers versus scraping it, when you scrape it out, you'll take the tissue out, it'll go to pathology. With the laser, you're actually evaporating the prostate tissue.
Which is more effective? No, you got my curiosity.
Most people would say, most of the studies say that they're pretty similar. Okay. I am a little bit biased. I actually, more oftentimes, will actually scrape out the prostate for a bigger prostate. I have partners that think that doing a laser is better. So I think a lot of it comes down to what the surgeon is most comfortable doing. But a lot of the studies have shown that they're very similar. They have a little bit different side effect profile. The lasers, have a little bit more frequency and urgency, maybe a little bit more irritative symptoms, just while the short-term healing period. That's usually done as an outpatient with most of the lasers. A lot of times a shorter catheter time with the laser, but with usually less blood loss with the laser too. Whereas I think that scraping it out, I think that's always been more we'll call it the gold standard.
That goes back, now we're scraping out, we're talking about transurethral resection or TURP.
Mm-hmm. Yep. Yeah, so a lot of people call it is a TURP, a roto-rooter.
Like coring an apple?
Coring an apple. Yes, it's all those things.
And how long does that take? And for our viewers, I'll share the fact that I went through it a number of years ago, and before I did it, it was like a last resort. I literally went into total bladder retention failure, could not urinate at all, had to have I was wearing a device for a while just where they were monitoring things, and I remember we had a grandson who was in diapers. I was wearing, my device, and we were at a circus at the old Pistons, the Palace, and my wife had to go to the bathroom. She had to, go up and use the bathroom, and my grandson and I, we had no problems with that. But I remember that it was agonizing, and finally I reached a point where just nothing worked. The catheter, when it was removed, was no good anymore, and they really had to do almost emergency surgery, and I had the TURP.
So that to me is if you're in a severe situation like that,
it was pretty agonizing.
Sure. If you can't urinate and if you can't empty your bladder, that hurts as your bladder gets really stretched out. To me, doing a TURP is, if you're only going to do one procedure, and you said, what is the best procedure to make sure I never have a problem again, you do a TURP.
But I've also heard that the prostate can grow back. Is that true? Or
it can, but the reoperation rate for that is pretty low. So I usually tell people it's a 1% chance per year for life. So in 1 year it's a 1% chance, 5 years 5%, 20 years 20%. So it still is very good.
And how long is the procedure for the TURP?
It depends a little bit on the size of the prostate. So it could take 25 minutes, it could take an hour, or even a little bit longer. I will tell you that usually the lasers are slower than actually scraping it out. I don't find that operative time, if it takes 45 minutes to do a TURP versus an hour and 15 minutes for a laser, I don't know that I'll base my decision on what treatment to do based on that extra half hour.
And it's an inpatient procedure. I think I was in the hospital overnight, if I remember correctly. And
right.
And then what is the recovery?
So typically for doing a TURP, lasers oftentimes we can send people home the same day. So it's done more as an outpatient. If you do a TURP, we actually scrape out the prostate. It's usually an overnight hospital stay. Catheter can stay in for 1 to 5 days typically. And then really the biggest risk is having bleeding issues afterward. So if you're more active, if you're doing any kind of exercise, you can potentially cause some bleeding in the prostate, which may have to have a catheter put back in if you're really having a lot of bleeding with that. Fortunately, it's not that common, and we try and tell people just take it easy for a couple weeks, just let it heal, and then you should be fine after that.
What are some of the problems or after effects that we should be concerned about?
Sure, I think what most people get concerned about is they lose the ability to control the urine. So if they're having urine leakage issues. Fortunately, that should be pretty uncommon. It should be probably about 1% or less in general. So, but I think that's always an important question to ask. In some instances, it can potentially affect your erections because the nerves that you have to control your erections run right alongside the outside of the prostate. And so if you are too deep in the prostate tissue, some of that energy that you use to remove the prostate can be transmitted to those nerves and cause erection problems. Bleeding issues or blood transfusions be a very rare event. Infections, are always potentially possible anytime you do any kind of procedure, but again, pretty mild or unlikely.
And what ages, I think you said really 50s and up, and when people start having prostate issues?
More commonly, yes. And then I would say maybe starting in their 50s, certainly as you get older, the instances keep going up.
And I think you said earlier that approximately 70% of all men are going to face some type of prostate issues?
Some type of prostate issues. Unfortunately, not many of us get to escape it. So it's pretty unusual when someone comes to the office and they're in their 80s and they're not on any prostate medication, they have no prostate urinary symptoms. It's an unusual situation. It does happen, but more than likely they're going to experience something.
Now, you said earlier that the TURP is the gold standard. Are there any changes in this area that are coming up now, or things that our viewers should be aware of?
I think that most of the changes with a TURP are really in the energy that's being used. So there is a bipolar type instrument which can actually decrease your blood loss during the procedure. It decreases some electrolyte abnormalities by doing that. That's been around for a little while. There's some other type procedures. There's a laser enucleation of the prostate. Not many people do it in this area where you actually, rather than evaporating the prostate tissue, you can use the laser to actually core out prostate tissue. It's a difficult procedure to do. I don't know if the results are that much better than doing the others, but for really large glands, that may be beneficial.
What do you find most rewarding about your specialty?
I think the ability to help people. I think having relationships with patients is great. You get to know them on a personal level, know something about them or about their family, and just knowing you've seen them. For most of us in urology, we hold on to our patients and we follow them for years over time. And actually to see the improvements that you've been able to do for them. Maybe it's doing a TURP and all of a sudden now somebody who couldn't urinate can urinate. I think that's pretty rewarding.
That's for sure. Any frustrations?
Always. I think it's more with with government and regulations and
yeah, I know.
billing and coding and computers and all that kind of stuff. More than, one of my friends who's a physician said, I love my calling, but I hate my job. Meaning that he loves taking care of patients. He loves seeing them and helping them and doing whatever they need to be done to improve their health, but he hates everything else that goes with it, meaning the office work, the managing the office staff, the electronic medical records, the HIPAA compliance forms, and everything, all the other paperwork that you have to deal with.
One of my friends who's a physician recently retired, and he loved the patients, but all these other things, he said finally enough was enough. I think we're out of time. Dr. Brian Seifman, I want to thank you so much for being my guest on Gracefully Graying, and I want to thank you for watching Gracefully Graying.